So I just want to say good morning and welcome to everyone to this special cervical cancer tumor board dealing with rare pathological variants of cervical cancer. I'd also like to welcome our colleagues from Latin America and around the world and our expert panelists at MGH and around other parts of the US. And to the doctors presenting the cases today, which we have previously presented in the past year in these cervix cancer tumor boards, but we were operating. These were all cases with rare pathologies, and we were operating with insufficient pathology knowledge and insufficient clinical consensus around optimal management. The cases today are going to be presented by Dr. Zaida Morenti from Lima, Peru, Dr. Ernesto Dominguez from Panama City in Panama, Dr. Maria Pilar from Sao Paulo, Dr. Maria Pilar and Dr. Julian Lima, both from Sao Paulo, and Dr. Angela Rodriguez from Minas Gerais in Brazil. I'd also like to extend a very warm welcome to our special guest pathologist, Dr. Robert Young. The way in which Dr. Young describes himself is that he has been head of the gynecologic and urologic pathology groups at MGH for many years, and has written extensively in those areas, including the writing of a number of books. He trained under a very famous pathologist called Robert Scully, and he is currently the Robert Scully Professor of Pathology at Harvard Medical School. To his colleagues, Dr. Young is described simply as a legend and the world authority on rare cancers of the cervix. So I'd like to emphasize our usual housekeeping rules for today, especially for first-time attendees. Please keep your microphones on mute unless you're speaking yourself. Then you just turn it on and turn it off when you finish speaking. And just as a reminder, all PowerPoint cases as well as the YouTube recording of today's discussion are being archived online for your or others' review. And so with that introduction, I'd like to get started, and we're going to have Dr. Zaida Morenti present our first case from Lima, Peru. Thank you, Dr. Morenti. If you just turn your microphone on, Dr. Morenti.
Good morning.
Good morning.
Good morning.
Okay, the first slide, please.
Just 1 second, please. Okay, you can put the next one. There's a picture of our panelist. Okay, Dr. Morenti, we're ready with your first case, please.
Okay, this case is about a 15-year-old female with the following background. Menarche at 13 years old, no sexual partners, no family history of cancer, and no history of DIS exposure. On November 2009, attended the outpatient clinic with 2 months history of pelvic pain, no other prior symptoms. With the consent of her parents, a gynecological examination was performed and showed a 3 centimeters ulcerated exophytic bleeding cervical mass, and a cervical biopsy was performed. The next, please. Okay. That biopsy informed clear cell carcinoma. The abdominal MRI showed primary neoformative process with cervical and iliac lymph node involvement and bilateral iliac bone metastasis. The chest CT showed multiple metastatic lung and liver lesions. The patient was seen in the emergency department in November for right leg severe pain, and she was diagnosed with fracture of the right ischiopubic branch. The final diagnosis was stage 4B cervical cancer. She received radiation therapy in pelvic fields as a palliative treatment on December 2009. Then she started chemotherapy with weekly paclitaxel times 12 until June 2010. The CT scan revealed disease progression, and she started a new treatment with carboplatin plus ifosfamide times 3 until August. Then she was considered that the disease was chemorefractory. And on October 2010, just received palliative treatment and was lost to follow-up.
So I think before we go into the discussion, perhaps we'd like to go over the slides of the patient's biopsy. So if you just hold on a minute, Jessica will put those slides up.
This is a low-power view of the neoplasm showing a very cellular process. Is there a pointer?
No, there's no pointer.
So
sorry, no, yeah. That's Jessica's got.
Oh yes, there is at least there's a cellular neoplasm.
Ellie, can you just give Dr. Young the chair next to the computer?
Which has largely got nondescript epithelial features, but the arrow is pointing to an apparent tubular gland. One can see there.
You want to go and use the tracker?
I don't think I can use it very much. The next slide.
Can you put your microphone on mute, please? Can you please mute your microphone? Hello, can you please mute your microphone? Can you please mute your microphone? Please mute your microphone. One of the rooms has got the microphone on. Can you please turn your microphone off? Dr. Morante?
We have the microphone on off.
Okay, just 1 second, please. Okay. All right. Sorry, Dr. Young.
Okay, if we can go back.
We'll just go back to the slides. Do you want to start again because there was a bit of confusion? So let's just start with the first slide again, pathology slide.
This low-power view shows a neoplasm, which is obviously very cellular, with, as we're outlining by the arrow here, at least one tubular gland indicating it's an adenocarcinoma. The cells at this low power have cytoplasm that looks rather pale to perhaps eosinophilic. Next slide, please. One feature of the cells in high power is rather abundant clear to pale cytoplasm. Next slide, I think, shows these to higher effect. And there's a small tubular gland just down at the 6 o'clock position. I think this was interpreted as a clear cell adenocarcinoma, which I find quite an appropriate diagnosis because there are cells with clear cytoplasm. But we need to remember that it's the patterns of clear cell carcinoma that are as distinctive as the presence of clear cells, and the tubular glands look fine for clear cell carcinoma. It's perhaps not the most distinctive example of clear cell carcinoma, but I think when one thinks of the subdivision of adenocarcinomas of the cervix, it certainly fits better there than anywhere else. The next slide shows some immunohistochemistry that was done. This is a slide showing some focal positivity for CD10. I don't think we would have got this stain candidly at our hospital. It's not a very specific stain, but so I will not make further comments on it. I don't think we would find it helpful. Next slide shows CK7, which is of course one of the cytokeratin stains, showing the expected strong brown positivity as one would anticipate for a carcinoma. And the next slide is of an EMA stain, which is another common marker of epithelial cells showing overt positivity. The next slide is estrogen receptor stain showing a negative reaction, which is anticipated for clear cell carcinoma, which is not generally positive for estrogen receptors. So that is as one would expect. And we may have one more slide. This is just this is actually a PAS stain. PAS stain was done in the old days in particular for clear cell carcinoma. It should actually show some positive staining for intracytoplasmic glycogen, which does not seem to be present here, but it may just be spurious due to the focus that was elected for this particular stain. But I don't, there was no, it was quite reasonable to do the stains, but I don't think they add very much to the diagnosis of clear cell carcinoma. I'll just comment that clear cell carcinoma, as was noted at the outset by our speaker, is famous, if I can put it that way, because of its association with in utero exposure to DES, but of course that practice ceased circa 1970 when that association was discovered, quotes unquote, at this hospital, and then of course DES was discontinued for obvious reasons. So at this point in time, we do not really see, for most practical purposes, any DES resultant cases of clear cell carcinoma of the cervix, or for that matter the vagina, where they also occur. But long before the DES situation came into play, clear cell adenocarcinoma was well known as an uncommon subtype of cervical carcinoma, usually seen in older patients. So this case of apparent clear cell carcinoma in a young girl is a distinctly rare neoplasm, so it's appropriate that it's one of the cases for the discussion. There was obviously a sizable neoplasm at presentation. Some of the clear cell carcinomas in the DES young ladies were found at a very early stage, and many of them did quite well. But as with so many cancers, obviously the mere size and stage of the tumor is as important, if not more important, than the subtype of the carcinoma. I think that's all right.
That's very good. Thank you, Dr. Young. So, we're back on microphone.
Yes.
So, I would like to ask our panelists and anybody who wants to comment on what is the way that a 15-year-old girl could be approached with this rare pathology, and which is even rarer in a 15-year-old. What would your approach be? Kathleen, would you like to start and maybe say what you think about the management of this rare cancer? And don't be shy if you don't know, because I'm sure nobody knows.
Personally, I've never seen anyone this young with this cancer. We do occasionally see clear cell carcinoma of the cervix. Anuja and I actually share a patient who had locally advanced disease, and we treated with chemoradiation and is without evidence of disease several years later. But it's a pretty rare entity. I don't know, Anuja probably sees more than I do.
We actually tend to treat clear cell of the cervix as a high-grade adenocarcinoma. So I'm really surprised that they use weekly Taxol and not carboplatin and Taxol as their systemic therapy. Because I mean, that's how we treat these clear cells, exactly as if they're high-grade adenocarcinomas. But this is a really young patient, and we probably wouldn't have seen this patient. This patient probably would have gone to pediatrics in the first place.
Right. Does anyone else want to comment?
I was trying to remember when was the last time that we saw a clear cell of the cervix here at Mass General. Probably I don't remember, like in the top of my head, like one case in the last 3 years. I don't know. I mean, it's just so rare that we rarely see it.
So this isn't just a rare pathology, but this is a very rare age group to see this pathology.
Yeah.
So there's really no standard of care, and there probably never will be clinical trials or first level 1 evidence what to do. So in the absence of that, just practically, what do you do? I mean, like in breast cancer, we don't have a lot of data from men with breast cancer, so we just simply treat them the way we treat women. We just borrow from the female guidelines. So is that what you do here? We've heard about the chemotherapy. What about the surgery and just the general approach to this case?
I think with metastatic disease and cervical cancer, there is very limited role for surgery. I think if she had localized disease, then you can think about it. But again, it's case-by-case kind of scenario.
But it should be considered generally as an aggressive cancer.
Yeah, I think the problem with clear cell histology across tumor primaries is that probably the molecular signature of these tumors may be similar, like meaning clear cell of the cervix, clear cell of the endometrium and ovary, but we treat them all the same based on their site of origin. But I think what we learned, at least from the Genome Atlas project in serous carcinoma of the endometrium, is that they have a different molecular signature. So I think in the absence of cases that allow us to do a randomized trial of these very rare histologies, we lump them into high-grade carcinomas based on their site of origin. So we would have treated here with carboplatin and Taxol systemically for stage 4B disease. But I think probably in the future what would be interesting is to try to get a sense of the genomic signatures of these tumors to try to see if there's a better targeted therapy that would lead to improved results.
So more research on the basic biology. And Dr. Young, you mentioned a few markers that have been performed on this case that you thought may be understandable but not that helpful. are there any markers that would you can you just remind us of what they were, and are there any markers you would do here now today that they didn't do? Is there anything?
No, I don't think so. They got standard immunohistochemical stains, and of course, what Dr. Del Carmen is discussing is obviously much more sophisticated molecular analysis. I think the stains that were performed once in a while could help you determine, of course, obviously carcinoma versus lymphoma and things like that weren't very realistic in the differential diagnosis here. So I think the conventional standard immunohistochemical stains have minimal role, except once in a while diagnostically. They certainly don't add anything to the management, as she was saying. It's for the future to perhaps come up with more sophisticated.
So if everybody would like to, the consensus seems to be, now MGH is one of the leaders in genetic mutations, genetic studies of tumors. Is this something that has been done yet at MGH that you're aware of, or is it something that should be done by this collective group, creating a bank of rare tumors and sending them to some central lab where some research can be done on them?
So I think not dissimilar to probably what's happening across a lot of different cancer centers in the United States is that we offer some of our patients, especially those with rare tumor types, the possibility of doing molecular genetics on the tumor to see if there's targeted therapy that would be appropriate or a phase 1 agent. But it's not standardized, I would say, here. We certainly have a tumor bank. So I think the future, I think, is in doing collaborative work where you could actually begin to...
but unlikely to ever do proper clinical trials because of the rare tumors. Yeah. At any rate, so I hope Lima, Peru heard that perhaps the chemotherapy choice might have been slightly different by the expert panel, and some of the immunostains weren't quite as useful, as helpful as they presented themselves, and that we need to do genomic studies on these cancers and perhaps form a unified biobank collecting biopsy material from these rare cancers. So can we have the second